This is a review of Chapter 10, Anxiety Disorders Review for the PMHMP for the ANCC exam. And it is straight information or recapped information from the PMHMP Review and Resource Manual, 4th edition, what they often call the Purple Book. There's hardly no personal notes, it's just a recap of the chapter. Anxiety can initially manifest as a number of physical illness states. Because of the high degree of somatic symptomology, it is common for clients to present to a primary care setting and thus receive initial care from a primary care provider. Anxiety is a very common and normal human emotion. PMHMPs caring for clients who present for evaluation of anxiety must be able to distinguish between normal levels of anxiety and pathological levels that are symptomatic of an underlying brain-based illness. Pathological levels of anxiety require treatment and generally will not fully abate without therapeutic intervention. Untreated high levels of anxiety predispose people to other serious health problems. Therefore, pathological levels of anxiety should not go untreated. Normal emotion of anxiety. Anxiety is one of the most common human emotions. Anxiety exists on a continuum ranging from the absence of anxiety at one end to pathological levels that produce significant symptoms of psychiatric disorder at the other end. Anxiety can be a normal, healthy reaction to life stressors that motivates a person to deal with events and emotions. Anxiety can be pathological if it is disproportionate to events, if it's sustained over a significant time frame, and if it significantly impairs functioning, or if it's apparently unrelated to any identifiable event or situation in a person's life. High pathological levels of anxiety interfere with perceptions, memory, judgment, and motor responses. There are 4 anxiety levels. Level 1 and 2 are mild to moderate, and there are no changes in vital signs. Level 1 specifically is normative level of anxiety that is experienced by everyone and functions to motivate us. Level 2 is also normative level of anxiety experienced by most of us in response to significant stressors. Usually the vital signs are normal, and it's a subjective feeling of tension or worry or narrowed perceptions. Level 3 I think is on the next slide. Anxiety level 3 and level 4 are both pathological. Anxiety level 3 is a pathological level. There's autonomic nervous system triggered, the flight or flight response, pupils dilated, vital signs, increased diaphoresis, muscle rigidity, hearing decrease, pain threshold increase, and urinary frequency and diarrhea. Okay. And there are perceptual field greatly narrowed, difficulty with problem solving, and distorted perception of time. Level 4 anxiety is also pathological, and there's the physiological symptoms are severe symptoms, marked increase in the client is pale, hypotensive, poor hand-eye coordination, muscle pains, dizziness, short of breath. And they are scattered perceptions, unable to attend to environmental stimuli, and illogical. Cultural differences can affect behavioral manifestations of anxiety. Ataque de nervios is a Latin cultural syndrome usually provoked by disruptions in family bonds and may be manifested by trembling, crying, and screaming. The attacks are usually experienced in the presence of others, and the person often feels relief afterward. Kyle wind attacks are common manifestations among Cambodian and other Asian cultures and commonly manifest in neck sores and tinnitus. Older adults often express anxiety as somatic concerns, and anxiety disorders may overlap with medical conditions. Psychotherapy is the first-line treatment of children and adolescents who are diagnosed with anxiety disorder. So psychotherapy is first-line treatment. The role of the PMHMP in assessing anxiety is to separate normal versus pathological levels of anxiety, to intervene to the lower level of anxiety, and to improve overall functioning. Anxiety disorders are the most common group of psychiatric disorders and are characterized by the degree of anxiety experienced by the client, the duration and severity of the anxiety, and by the typical behavioral manifestations observed in the client. Anxiety ranges from acute states to chronic disorders and is accompanied by multiple somatic symptoms. People most often present first in primary care settings with nonspecific physical concerns. Panic attacks are often confused with cardiac and respiratory disorders, so careful differential diagnostic assessment is essential. Frequent comorbidity exists with substance abuse, depression, and eating disorders. Symptoms significantly impair functioning and occur more days than not for a period of at least 6 months, with the person reporting little or no volitional control over the symptoms. 9 specific anxiety disorders are identified in the DSM-5. The etiology of anxiety. Multiple theories range from psychological to neurobiological. However, most likely there is a multifactorial etiological profile. We'll start with the psychodynamic theory. This theory is based on work by Sigmund Freud, who believed that anxiety initially occurs in response to the stimulation of birth and the need of the infant to adapt to the changed environment. Subsequent anxiety results from intrapsychic conflict. The process of unconscious repression of sexual drive is at the core of much of the conflict. Conflict exists between the instinctual needs of the id and the superego, the conscience. Anxiety signals a person of the need to deal with the id superego conflict. Conflict is unconscious, but anxiety is consciously perceived. Conflict entails fear of punishment and of doing wrong. Defense mechanisms are unconsciously used by the person to deal with the conflict. The behavioral manifestations of anxiety disorders stem from the pathological overuse of these defense mechanisms. The interpersonal theory. This theory is based on the work of Harry Sullivan, who believed that humans are goal-directed toward attainment of satisfaction and security needs. Satisfaction and security needs are normally met with interpersonal interactions. Anxiety arises when a person's needs are unmet. Anxiety is first experienced in an infant's interactions with his or her mother, and subsequent anxiety arises because of interpersonal conflict. Conflict occurs when a person perceives his or her needs will not be met because of rejection, feelings of inferiority, or inability to engage with significant others. A sense of self becomes based on the person's perceptions of how others view him or her. Neurobiological theory. Pathological levels of anxiety result from neurobiological deficits in normal brain functioning. Deficits are genetically mediated by and involve predominantly the limbic system, the midline brain system area, and sections of the cortex. Deficits predispose the person to abnormal stress responses with hyperactivity of autonomic nervous system, causing symptoms such as increased heart rate and blood pressure, diaphoresis, pupillary dilation, tremors, and increased respiratory rate. Problems with the hypothalamic pituitary adrenal axis, or HPA axis. That is where there's a threat is perceived, and the amygdala signals the hypothalamus to secrete corticotropin-releasing hormone, CRH. The amygdala also activates the sympathetic nervous system to start the fight or flight response. The pituitary is stimulated to release adrenocorticotropin-releasing hormone, that's ACTH, and the adrenal glands are then stimulated to release cortisol, which shuts off the alarm system and restores the body to homeostasis. In anxiety disorders, the amygdala may not be able to shut off the response of the overactive amygdala, or there may not be enough cortisol to stop the fight or flight response. Neurobiological deficits result in low levels of the neurotransmitter GABA, the chemical responsible for the inhibitory responses of neurons, and in high levels of norepinephrine, the chemical associated with the flight or flight response, fight or flight. Neurotransmitters involved in suppressing the HPA axis are serotonin and GABA. So neurotransmitters involved in suppressing the HPA axis are serotonin and GABA. Incidence and demographics. Anxiety disorders are common with a lifetime prevalence of 28.8% among the general U.S. population. Except for obsessive-compulsive disorder and social phobia, anxiety disorders are generally more common in girls than in boys. Most anxiety disorders manifest in adolescence and early adulthood. Most anxiety disorders manifest in adolescence and early adulthood. The median age at onset of anxiety disorders is 11 years old. Risk factors. Genetic loading. A first-degree relative of a person with panic disorder is up to 8 times more likely than the general population to develop panic disorder. If a first-degree relative of a person developed panic disorder before the age of 20, the person is up to 20 times more likely than the general population to develop panic disorder. Limited range of coping skills, history of trauma, and high levels of parental distress affecting a child's ability to cope with traumatic events. Teach at-risk persons to recognize and manage anxiety levels and help at-risk persons reduce anxiety through improved coping activities. Assessment. Assess for the following: detailed history of present illness, including time frame and progression of any associated symptoms. Social history, including present living situation, marital status, occupation, and education. Medication use, including prescription, over-the-counter, alternative supplements, and home remedies. The clients initially may be more troubled by and complain more often of physical symptoms and may not identify anxiety as a concern. Explore the client's subjective sensations of being nervous, tense, worried, anxious, or stressed out. Identify current environmental stressors as experienced by the client. Determine if the anxiety is normative or pathological. Pathological levels of anxiety are indicative of underlying anxiety disorders. Anxiety is perceived as a distressing and out of control to the person. Anxiety is unlinked and not seen as caused by life events. Anxiety is accompanied by somatic complaints, which is more uncommon in normal anxiety levels. Anxiety interferes with social, occupational, and recreational activities and activities of daily living. Determine the level of the client's anxiety using the 4-point scale of mild to panic levels. 1 equals mild and 4 equals panic. Use standardized rating scales such as the Hamilton rating scale for anxiety in order to establish and monitor the client's anxiety level over time. Assess the general level of health and presence of concomitant illnesses, and assess for dysfunctional coping such as alcohol, substance use, caffeine, nicotine, and or misuse of anti-anxiety medication. Assess for specific psychological symptoms of anxiety, such as fear of dying, losing one's mind, or a sense of unreality, belief that he or she is very ill, with no findings to support this belief, narrowed perceptions, and limited eye contact. Possible physical manifestations are diaphoresis, headaches, dizziness, lightheaded, missing hair on the scalp or eyebrows or eyelashes for trichotillomania or excoriation disorders, pupillary dilation, increased muscle tone, palpitations, often with tightness in the chest, tachycardia, hypertension, and GI problems such as nausea, diarrhea, or abdominal discomfort. Mental status findings for appearance or psychomotor: restlessness, tremors, hand-wringing, speech is overproductive, rapid, distractible speech patterns, or thought blocking. The mood is nervous or worried, and affect is anxious, worried, or tearful. The thought process is overall organized, goal-directed, and redirectable. The thought content is thematic for worry, mild perseveration on topics of concern. Orientation usually is fully oriented. Memory is impaired short-term and immediate memory, forgetful. Concentration is inattentive, decreased concentration. Abstraction is abstract on proverbs and similarities. Judgment is intact, and insight is intact or limited insight. For diagnostic and laboratory findings, obtain baseline labs such as the CBC, chem profile, thyroid function, B12, and to rule out metabolic causes or unidentified conditions. Obtain a drug toxicity screening if indicated by history. Again, that's across the board. In some cases, clients may have labs reflecting compensated respiratory alkalosis, decreased carbon dioxide levels, decreased bicarbonate levels, and a normal pH. Differential diagnosis. Many conditions can cause worry, fear, and normal levels of anxiety. Ensure that the client's symptoms meet criteria for anxiety disorders. General clinical management. Rule out or treat any conditions that may contribute to pathological levels of anxiety. Medical conditions that may mimic anxiety disorders are cardiovascular, such as congestive heart failure, infarction, arrhythmias, respiratory or asthma, COPD or pneumonia, endocrine, could be hyperthyroidism, hyperparathyroidism, or Cushing's disease. Neurological could be seizures, TIAs, CVAs, encephalitis. Metabolic could be hypoglycemia, vitamin B deficiency, and substance abuse or dependency could be intoxication with stimulants such as cocaine and amphetamine, or withdrawal from CNS depressants such as alcohol or marijuana. Pharmacological management. Most of the medications known to improve symptoms of anxiety act directly or indirectly on the GABA system. Selective serotonin reuptake inhibitors, SSRIs, are considered the first-line agents for chronic anxiety disorders. Action on the serotonin system and indirectly on the GABA system. They carry no risk of dependency. They cannot be used as PRN. Generally, they are well tolerated, and it takes time to reach symptom control. Usually for anxiety, it's 3 to 4 weeks. So for depression, it's 4 to 6 weeks, but SSRIs for anxiety usually take 3 to 4 weeks. They work best when combined with psychotherapy. There is a black box warning, as we know, with SSRIs for increased suicidality in children, adolescents, and young adults. Okay, benzodiazepines. They potentiate the effect of GABA. They have a rapid onset of action. They can be used as PRN. However, limit to the lowest possible dose and short-term use if possible, because long-term use may lead to tolerance, dependence, memory impairment, and depression. Use should be limited to period of excessive symptom, period of high stress, or in unremitting symptoms. Use benzodiazepines with extreme caution in clients with history of substance dependence. They are effective, but they carry a risk for addiction, especially in persons who have a history of substance abuse. The use of benzodiazepines has been associated with Alzheimer's disease. Benzodiazepines with longer half-lives require less frequent dosing, they have less severe withdrawal, and they have less rebound anxiety. So that's benzodiazepines with longer half-lives. Benzodiazepines with longer half-lives are more useful for continuous to moderate to severe anxiety or as a bridge medications while waiting for the efficacy of the SSRIs. Some examples of benzodiazepines that have longer half-lives are clonazepam, which is Klonopin, and diazepam, which is Valium. Benzodiazepines with shorter half-lives require more frequent dosing, have more severe withdrawal, and have more rebound anxiety. Examples of benzodiazepines with shorter half-lives are alprazolam, which is Xanax, and lorazepam, which is Ativan. Advantages of benzodiazepines with short half-lives are that they are often useful for intermittent or infrequent moderate to severe anxiety, less daytime sedation, less drug accumulation, and quick onset of action, useful for the treatment of insomnia. The disadvantages of benzodiazepines with short half-lives are that there is an increased risk of addiction. Tricyclics, or TCAs, are effective but affect multiple receptors and have problematic side effect profiles. Side effects often affect compliance. Non-benzodiazepine anxiolytics are Buspar, buspirone, which must be taken regularly, not as PRN. Tiagabine or Gabatril, which is off-label, gabapentin, Neurontin, also off-label, and beta blocker propranolol, altenolol, also off-label, and usually adjunctive use with other pharmacological agents. Buspar, the dosage range is 20 to 60. Some side effects are dizziness, insomnia, tremors, akathisia, stomach upset, and dry mouth. Comments, it says helpful adjunct for anxiety. Tiagabine, I'm not sure if I'm pronouncing that, and Gabatril, which is Gabatril, the usual dosage range is 4 to 56. Side effects are dizziness, somnolence, stomach upset, tremors, and dry mouth. and some comments are helpful adjunct for anxiety off-label. Gabapentin Neurontin, usual dosage range is 300 to 3,600 milligrams per day. Side effects are ataxia, decreased coordination, sedation, and disequilibrium. Comments are used for anxiety, neuropathic pain, fibromyalgia, and as an anti-craving medication, and off-label use. Propranolol, Inderal, the usual dose is 10 to 20 milligrams, can be used daily as needed. The side effects are hypotension and bradycardia, and some comments are performance anxiety. So propranolol, Inderal is good for performance anxiety, and it is off-label use. In children, alpha agonists are often used for anxiety, such as clonidine, catapres, and guanfacine Tenix, and both of those are off-label for anxiety for children. Non-pharmacological management are behavioral therapy, systemic desensitization, exposure therapy, relaxation techniques, and biofeedback. Cognitive behavioral therapy, interpersonal therapies, community self-help groups, and alternative therapies as adjunctive treatments. Comorbidities are anemia, cardiac disorders, especially in clients with dysrhythmias, endocrine disorders, Cushing, hyperthyroidism, hypoglycemia, pulmonary conditions such as COPD, asthma, pneumothorax, even adverse medication reactions, caffeine, nicotine, anticholinergics, antihistaminics, antipsychotics, steroids, bronchodilators, and substance abuse related disorders. And these are all comorbidities. Okay. Yep. Chronic anxiety is wearing on the body. Therefore, assess for effects on the cardiovascular system. Perform a general assessment for a healthy lifestyle. General considerations. Clients should initially be seen weekly or bi-weekly to titrate medications. Client teaching should include risks, benefits, and potential side effects of medication treatment. If the client is taking benzodiazepines, monitor for appropriate use and potential dependence. If the client is taking SSRIs, monitor for common side effects and adverse effects. Clients should be taught symptoms of anxiety and the fact that these disorders are often chronic. A relapse plan should be established for all clients. In anxiety, assessment for suicidality should occur during systemic exacerbation periods. Most of the other suicidality recommendation assessments have been at all patient encounters, but the authors have written that assessment for suicidality and anxiety should occur during symptom exacerbation periods. Okay. Because of frequent comorbidity with major depressive disorder, assess frequently for depression using standardized rating scales. Medications should be combined with therapy to reach maximum control of symptoms. Clients may need encouragement to continue treatment, especially after initial symptom relief. Some standardized rating scales for anxiety disorders are the Zung's Self-Rating Anxiety Scale, Zung. Then there's the Hamilton Rating Scale for Anxiety, HAM-A, and the Yale-Brown Obsessive Compulsive Scale, Y-BOX, Yale-Brown Obsessive Compulsive Scale. Panic disorder. Panic disorder is experienced as discrete episodes or attacks with sudden onset of intense apprehension, fearfulness, or terror, often associated with a sense of impending doom. Attacks occur without warning and in the absence of any real danger. Attacks build to peak of intensity within a short self-limiting time, usually 10 minutes. Panic disorder is more common in women than in men. Assessment. Assess for the following. The diagnostic criteria of panic disorder is a discrete episode in which the client experiences 4 or more of the following symptoms, having a sudden onset and peaking within 10 minutes of the onset. And the symptoms are paresthesias, chills or hot flushing, fear of losing control or going crazy, fear of dying, shortness of breath or smothering sensation, palpitations, pounding or accelerated heart rate, chest pain, tightness, or discomfort. Also, sweating, trembling or shaking, nausea, abdominal distress. After the first attack, persistent concern over having another attack, worry of the consequences of the initial attack, or a significant behavioral change related to the attack. With high somatic sensations, clients are often sensitive to new somatic experiences or perceptions, often intolerant or concerned with common side effects of medication treatments, discouraged or ashamed about the failure to control emotions, and over-concerned about dying when no other pathology is identified. In 2/3 of the cases, major depression occurs first, followed by panic disorder symptoms. In 1/3 of the cases, panic disorder symptoms precedes major depression symptoms. Physical exam findings. Nonspecific, especially when the client is not experiencing a panic attack. Nonspecific cardiac-related complaints during panic episodes often bring the client to treatment, such as chest pain, numbness and paresthesia, and shortness of breath. Mental status findings. General findings of anxiety as described earlier. Findings very pronounced during panic episodes and less pronounced during non-panic episodes. High level of anticipatory anxiety between panic episodes. Differential diagnosis. Rule out general medical conditions known to produce similar symptoms, including hyperthyroidism, hyperparathyroidism, pheochromocytosis, which is a tumor of the adrenal gland, causing there to be too much norepinephrine release and increased blood pressure. Vestibular dysfunction, such as disturbances in balance, vertigo, nausea, and vomiting. And seizure disorders, cardiac arrhythmias, such as supraventricular tachycardia or SVT, and the use of CNS stimulants, including cocaine, amphetamine, and caffeine. Another anxiety disorder, such as post-traumatic stress disorder or phobias, separation anxiety disorder, and consider a general medical disorder if the first episode of the panic attack symptoms occurs after the age of 45. Panic symptoms that are atypical are vertigo, loss of consciousness, incontinence, headaches, slurred speech, amnesia, or amnestic patterns after the attacks. Those are not typical of panic disorder. And differentiated from other anxiety conditions by sudden onset of the attack, discrete self-limiting nature of symptoms, paroxysmal symptom profile, meaning sudden and short-lived, and level 3 to 4 anxiety symptoms with somatic symptoms that are experienced as distressing and severe by the client. Pharmacological management for panic disorder are SSRIs. Benzodiazepine are usually used for short-term symptom control or bridge medication when starting an SSRI or other antidepressants. Buspar is effective as an adjunct to an antidepressant, and other non-benzodiazepine anxiolytic medication may be used as adjuncts. Non-pharmacological management could be CBT, individual or group therapy, exposure therapy, and relaxation therapies. Common comorbidities frequently occur with major depressive disorder. It's estimated that between 10 to 65% of people, depending on the source, have comorbidities such as social phobia, OCD, and substance abuse. Agoraphobia. Agoraphobia is characterized by avoidance of places or situations from which escape may be difficult or embarrassing, or in which help may not be available in the event of perceived need, such as a panic attack. Up to 50% of people meet criteria for agoraphobia also report panic attacks or panic disorder preceded the onset of agoraphobia. The anxiety usually leads to avoidant behavior that impairs a person's ability to travel, work, or carry out responsibilities of daily living. Differential diagnosis is assisted by the awareness that people with agoraphobia feel better and report less significant concerns with anxiety when accompanied by a trusted companion. When people meet criteria for agoraphobia and panic or anxiety disorder, both should be diagnosed and or assigned. Assess the following. Clinical presentation meets diagnostic criteria for agoraphobia. The presence of agoraphobic anxiety related to fear of developing panic-like symptoms, and avoidant behavior as a result of the agoraphobic anxiety. Pharmacological management. For agoraphobia are SSRIs, benzodiazepines for short-term use, and beta blockers off-label used for discrete episodes of social anxiety. So that's pharmacological management of agoraphobia. Non-pharmacological management are CBT, supportive group therapy, and desensitization therapy. Common comorbidities are panic disorder. Specific phobias used to be called simple phobias. The description is, in specific phobias is a clinically significant level of marked and persistent fear that is clearly observable by the client's perception, clearly related to specific objects or situations. In adults, but not in children, exists the conscious recognition that the fear is excessive or unreasonable. In children, the degree of insight to the unreasonable nature of the fear increases as age increases. Risk factors for specific phobias are traumatic past exposure, such as having been bitten by a dog, having choked on food, and so forth. Observation of another's trauma, that's another risk factor, such as seeing others be bitten by a dog or seeing others choking on food and so forth. And excessive informational transmission, such as repeated graphic parental warnings of dangers of certain events or situations. So that is excessive informational transmission. Genetic loading, which is having family member with specific phobia. And blood injection injury type is the most familial. The subtype aggregation pattern noted with families, for example, if a person has a first-degree relative that has an animal subtype, the risk is highest for him or her to develop the animal subtype. Assess the following: the content of the phobia, which can vary with culture, ethnicity, and age. Phobic diagnosis should occur only when accompanied by significant functional impairment, such as full avoidance of school related to fear of the encountering, for example, a spider. Exposure to the specific feared object or situation immediately provokes the onset of clinically significant levels of anxiety. The anxiety may fit the criteria for acute panic attack. The level of anxiety is directly related to how physically close the object or situation is to the person and the degree to which escape from the object or situation is possible. Children manifest fear and anxiety as crying, freezing, tantrums, or excessive clinging behavior. Children normatively express a transient fear of animals and other natural objects. Person engages in avoidant behavior to prevent reaction to object or situation, or endures object or situation the object or situation with dread. Avoidant behavior is distressful and has implications for social, recreational, and occupational or school functioning. There are five common subtypes: situational, natural environment, blood injection injury, animal, and other. A person can experience more than one subtype at a time. A phobia to one object or situation in a subclass predisposes a person to another phobia with the same subclass, such as fear of rats increases the risk of fear to spiders. Situational type is cued by specific situations. Examples include driving, being in enclosed spaces, tunnels or bridges, or flying. The most common adult form. In older adults, fear of closed-in situations is the most common. Bimodal peak of onset. So first peak is during childhood and the second peak is about mid-20s. Natural environment subtype is fear cued by objects in the natural environment. Examples include storms, lightning, water, or heights. And the natural environment subtype is the second most common adult form, and the onset is usually during childhood. The blood injection injury type is cued by seeing blood or an injury or by receiving an injection or other invasive medical procedure. It's the third most common adult form. There's a strong vasovagal component that can produce some somatic sensations, may exacerbate underlying cardiac or respiratory disorders. Persons often present with fainting as a chief complaint. Experiences are paroxysmal tachycardia and hypertension, followed by declaration of heart rate and drop in blood pressure. Clinical presentation and disease: natural history similar to panic disorder with agoraphobia. The animal subtype is fear cued by animals or insects. Examples include rats, snakes, spiders, dogs, and it's the fourth most common adult form. The onset is usually during childhood. The fifth subtype of phobia is fear cued by range of other stimuli. Examples include fear of choking, vomiting, or fear of a specific illness. That's just other type. In children, it often manifests as a fear of loud sounds or costumed characters. Differential diagnosis: avoidance behavior in PTSD, OCD, separation anxiety disorder, or psychotic disorders. Pharmacological management of specific phobias are SSRIs, TCAs, and short-term use for benzodiazepines. So that's SSRIs, TCAs, and short-term use with benzodiazepines. Non-pharmacological management of specific phobias are CBT, biofeedback, and desensitization therapy. Social anxiety disorder. Social anxiety disorder. The description is: social anxiety disorder is a marked and persistent fear of social or performance situations in which embarrassment may occur. Anxiety levels often are sufficient to fit criteria for a situationally bound panic attack. The disorder has an estimated 3 to 13% prevalence rate among U.S. population, and the rates are equal for both genders. Assess the following. Some degree of social anxiety is common and normative in adolescence. Social phobia should be diagnosed only if the symptoms persist for longer than 6 months. Social phobia should be diagnosed only if the symptoms persists for longer than 6 months. Onset is in the mid-teens, often following stressful or humiliating experience, and tends to remit with age. Differential diagnosis is assisted by awareness that people with social phobia do not feel better or experience decreased anxiety when accompanied by a trusted companion. So with agoraphobia, they do feel better when they're with a trusted companion, but in social anxiety, they don't feel better when they're accompanied by a trusted companion. Common descriptive features are hypersensitivity to criticism, negative self-evaluations, sensitivity to rejection, low self-esteem, inferiority feelings, and lack of assertiveness. Physical exam findings for a person who is acutely anxious: sweating, tremors, palpitations, muscle tension, diarrhea, and blushing. Mental status exam findings are consistent for anxiety, thought content consistent with criteria for social anxiety. Pharmacological management of social anxiety disorder are SSRIs, benzodiazepines for short-term use, and beta blockers used for discrete episode relief, for example, before having to attend a school function. Non-pharmacological management of social anxiety disorder is CBT, exposure therapy, and relaxation therapy. Generalized anxiety disorder is excessive worry, apprehension, or anxiety about events or activities that occurs more days than not for a period of at least 6 months. So social anxiety disorder and general anxiety disorder can't be diagnosed until the symptoms are occurring for a period of 6 months. The person finds it hard to control the anxiety. There's no clear link that exists to life stressors or events, and worry and anxiety interfere with activities of daily living, and the nature and focus of the worry shift frequently. For generalized anxiety disorder, the nature and focus of the worry shifts frequently, and there is a pattern of waxing and waning of symptoms that exists. Symptoms worsen as life events or stress happens to the person. Assess the following. In generalized anxiety disorder, anxiety and worry are out of proportion to the actual likelihood or effect of the feared event. People report subjective distress caused by constant worry, but do not always describe the worry as excessive. Excessive anxiety and worry last for more days than not for a period of at least 6 months, and the person finds it difficult to control the anxiety. Differential diagnosis for generalized anxiety disorder are PTSD, adjustment disorder with anxiety, obsessions in OCD, and anxiety associated with another disorder such as hypochondriasis or social phobia. Physical findings of GAD are nonspecific and associated with other health states such as irritable bowel syndrome, migraines, muscle twitching, tremors, general aches, numbness, fatigue. The list is long, but those are just a few. The mental status exam findings in general anxiety disorder are the appearance, their psychomotor restlessness, the mood is anxious, feeling keyed up or on edge and irritable, concentration, there's difficulty in concentrating. The thought content is thematic for the anxiety and worry, and descriptive of the significant distress and impairment in daily functioning caused by general anxiety disorders. Pharmacological management is with SSRIs, Buspar, and benzodiazepines as needed agents. Non-pharmacological management of generalized anxiety disorder, these are good candidates for therapy as single treatment modality. So for generalized anxiety disorder, these are good candidates for therapy as a single treatment modality. So cognitive behavioral therapy, relaxation therapies, stress management, and supportive counseling. Common comorbidities are mood disorders, other anxiety disorders, and substance use related disorders. Lifespan considerations in children. Anxiety is common in children, but it is important to assess normal levels versus pathological levels. Anxiety is manifested in excessive worry over competence or quality of performance in school, work, sports, or other activities. Common worry often manifests as anxiety over punctuality or catastrophes such as earthquakes or war, often accompanied by overly conforming behavior, perfectionist self-expectations, and excessive seeking of approval of others, or the need for frequent reassurance about performance. Separation anxiety disorder is developmentally inappropriate and excessive distress occurring after the age of 4 when faced with separation from a major attachment figure. May persist into adulthood, and in the DSM-5 it can be diagnosed in adulthood. Moving on to obsessive compulsive disorder, or OCD. OCD is the presence of anxiety-provoking obsessions or compulsions that function to reduce the person's subjective anxiety level. So it's obsessive thoughts and or compulsive behavior. Obsessive thoughts and or compulsive behavior. Obsessions or obsessive thoughts are defined as recurrent and persistent thoughts, impulses, or images that are experienced and cause anxiety and distress. Experienced as intrusive and inappropriate. Ego dystonic experience in which a person feels the content of the obsession is alien to his or her belief structure and not the kind of common thought or impulse or image that he or she usually experiences. Compulsions are defined as repetitive behaviors or mental actions that a person feels driven to perform in response to an obsession. Risk factors. There's a genetic predisposition, there's familial transmission pattern, disease rates higher in people with a first-degree relative who has OCD than in the general population. Rates are also higher in people with first-degree relatives who have Tourette's syndrome than in the general population. PANDAS, or pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, should be considered in all children with sudden onset of OCD symptoms. PANDAS in all children with sudden onset of OCD symptoms. And I was so focused to repeat that twice, I forgot to change the slide with a cute panda on it. Assess the following. The diagnostic criteria is the presence of either obsessions or compulsions, and the person recognizing that the obsession or compulsion is excessive or unreasonable. The obsession or compulsion is usually marked with stress and is time-consuming or interferes with normal daily activities. Common obsessions include repeated thoughts about contamination, dirt, or germs, repeated doubt, such as having hit someone with a car or having left an oven on or without evidence. Left the oven on without evidence. Need to have things in a specific order with marked distress when that order is disrupted, aggressive or horrific thoughts, and may occur in pregnancy and postpartum periods and manifest as intrusive thoughts about something happening to their baby or doing something to their baby. The thoughts are highly ego-dystonic. And sexual imagery. The obsessions usually do not involve real-world worries such as concern over finances. The person recognizes these thoughts, impulses, or images as a product of his or her own mind. The person attempts to ignore or suppress thoughts, impulses, or images, or to override them with other thoughts or actions. People often avoid situations in which the content of obsession may be encountered, such as avoiding public restrooms in order to avoid contamination. Common compulsions include repetitive actions, actually behavioral, and often called rituals, such as hand washing, excessive cleaning, checking to see, for example, if the lights are turned off, the stove is turned off, or the doors are locked, needing to place objects in certain order. Common mental actions include counting, silently repeating words, or praying. Behaviors or mental acts are not experienced as pleasurable and are intended to prevent or reduce distress and subjective anxiety. If the person resists the compulsion, anxiety and subjective tension usually increases. Some people believe that the compulsion can prevent some dreaded event or situation that is experienced as an obsession, such as sexual or horrific images. Physical findings in OCD. Dermatitis may be present related to excessive hand washing or overuse of caustic cleaning agents. Hypochondriasis and somatic fixation is common. The mental status exam findings is consistent with findings for anxiety. The thought content is dominated by the obsessions, and behavioral manifestations of rituals may be noted. Differential diagnoses are body dysmorphic disorder, eating disorders, trichotillomania, and hypochondriasis, obsessive compulsive personality disorder, or tic or stereotypic movement disorder. Pharmacological management of OCD are SSRIs. Clients often need higher doses or dose ranges of SSRIs in order to achieve adequate symptom control. Then there are TCAs, such as clomipramine, and second-generation antipsychotics such as risperidone are off-label but may have data supporting their adjunctive use with SSRI medication. Non-pharmacological management of OCD is cognitive behavioral therapy and exposure therapy. Common comorbidities are major depression, eating disorders, and anxiety disorder. Again, common comorbidities of OCD are major depression, eating disorders, and anxiety disorders. Lifespan considerations. In children's, OCD is common in childhood, usually with pre-pubertal onset, more often in boys than in girls. Washing, checking, and ordering are the most common behavioral manifestations with children with OCD. Common comorbidities in children with OCD are learning disorders, disruptive behavior, and Tourette's disorder, associated in children with group A beta hemolytic streptococcal infections. That's with children. And older adults, with OCD, there's more obsessions than compulsions usually present. Obsessive content is characteristically about dying, and compulsions characteristically about washing and cleaning for older adults. And the last disease process for the anxiety disorders is post-traumatic stress disorder, or PTSD. PTSD is the experiencing of an extremely traumatic event accompanied by symptoms of increased arousal and avoidance of stimuli associated with the trauma. The traumatic event can be experienced directly or witnessed. Common experienced trauma includes military combat, violent personal assault such as robbery or rape, kidnapping or hostage situation, terrorist attack, torture, prolonged sexual abuse, or natural or human-made disasters. Common witness trauma includes observing the death of or significant injury to another person, unexpectedly witnessing any of the above traumas, and learning of the sudden or unexpected death of a significant injury to a family member or a close friend. A relationship exists between the person's physical proximity to the traumatic event and the likelihood of the symptom onset. Risk factors for developing PTSD are experiencing or witnessing a trauma and genetic predisposition. Assumed PTSD is assumed to have a strong genetic ideological component and tends to run in families. A history of major depressive disorder in a first-degree relative increases the risk of developing PTSD. In PTSD, symptoms cannot predate the exposure to the trauma. Presenting symptoms and history can be delineated as one of the three subtypes: acute, chronic, or delayed onset. Acute is duration of symptoms is less than 3 months. Chronic is symptoms lasting 3 months or longer, and delayed onset is at least 6 months between the traumatic event and the onset of the symptoms. Physical findings for PTSD are nonspecific. There is increased rates of somatic complaints. Insomnia frequently is a chief complaint on the presentation for the evaluation. Distractibility in motor tasks. Measurable increased autonomic symptoms such as tachycardia, diaphoresis, increased respiratory rates, pupillary dilation, and increased startle response. Mental status exam findings are consistent finding for anxiety. Thought content consistent with criteria for PTSD and other dominated by traumatic experience, and may demonstrate some psychotic findings during the flashback episodes. Diagnostic criteria for PTSD are that symptoms must be present for 1 month or longer. Less than 1 month, I believe it's acute stress disorder. Anyway, symptoms need to be present for 1 month or longer. And there's exposure to a traumatic event. The person experienced, witnessed, or was confronted with an event involving the actual or threatened death or serious injury, and the person's response involved intense fear, helplessness, or horror. The word "and" is bolded, so I'll repeat it. And the person's response involved intense fear, helplessness, or horror. The traumatic event is persistently re-experienced in one or more of the following ways: recurrent and intrusive distressing recollection of the event, including images, thoughts, and perceptions, may be experienced as flashbacks. Rare cases involve dissociative states lasting hours to days. Recurrent distressing dreams about the event, acting or feeling as if the traumatic event were reoccurring. Intense psychological distress at exposure to cues that symbolize or resemble aspects of the traumatic event, and physiological reactivity on exposure to cues that symbolize or resemble aspects of the traumatic event. 3 or more avoidance symptoms. 3 or more. Persistent avoidance of stimuli associated with a traumatic event and numbing of responsiveness. Efforts to avoid talking about or thinking about the traumatic event. Avoidance of activities, places, or people that arouse recollections of the traumatic event. Inability to recall important aspects of the event. Marked decrease in interest of participation in activities. Feelings of detachment or estrangement from others, restricted range of affect, sense of foreboding, and shortened future, premature death, or no expectation for success or happiness. And 2 or more increased arousal symptoms. Arousal symptoms are persistent symptoms of increased arousal, such as difficulty falling asleep, irritability or outburst of anger, difficulty concentrating, hypervigilance, or exaggerated startle response. Symptoms causing significant distress or impairment in activities of daily functioning. Symptoms usually occur within 3 months of the trauma. Duration of symptoms are highly variable. Symptoms remit within 3 months in 1/2 of the cases, and common waxing and waning of symptoms related to internal and external cues that resemble the trauma. Differential diagnoses for PTSD are adjustment disorder, brief psychotic disorder, acute stress disorder, and intrusive thoughts and OCD. Pharmacological management of PTSD are SSRIs, TCAs, antipsychotics for the flashbacks, and alpha antagonists such as prazosin for nightmares. Benzodiazepines are not recommended in the treatment of PTSD. Non-pharmacological management of PTSD are CBT, exposure therapy with response prevention, supportive group therapy, relaxation therapies, and eye movement desensitization and reprocessing, or EMDR. Common comorbidities for PTSD are major depression, dysthymia, substance abuse, or dependence. Lifespan considerations. PTSD can occur at any age, including childhood. Children, expression of fear and horror occurs in disorganized or agitated behavior. Repetitive play behaviors show themes or aspects of trauma. Frightening dreams without recognized content are common. And in young children, learning that a traumatic event occurred to a parent or a caregiver may be the precipitating factor. Dissociative disorders. Dissociative amnesia, depersonalization or derealization, and dissociative identity disorder. Dissociation is a defense mechanism that protects a person from overwhelming anxiety by emotionally separating. Dissociation causes gaps or interruption in the person's memory. Depersonalization or derealization is a persistent feeling of oneself not being real or the environment not being real. Reality testing remains intact. Depersonalization and derealization are generally perceived as uncomfortable. Etiology of depersonalization and derealization can be physical or psychological. Physical causes are seizures, migraine headaches, psychedelic drugs, and alcohol, and psychological causes are severe anxiety or traumatic stress. Dissociative identity disorder is characterized by two or more distinct personality states or alters. Personality states are generally split off from one another, leading to gaps in recall of everyday events. Symptoms cause significant distress and impaired functioning, comorbid with PTSD, and the etiology is a history of severe physical or sexual trauma, or both, in childhood. Body dysmorphic disorder is the preoccupation with one or more perceived defects or flaws in physical appearance, engages in repetitive behavior, checking the mirror, reassurance seeking, etc., in response to appearance concerns. The preoccupation causes considerable distress. The insight ranges for body dysmorphic range from good to poor to absent. Hoarding disorder is persistent difficulty discarding possessions regardless of the actual value, experiences marked distress in response to the pressure to discard the items, results in accumulation of possessions that compromise daily living space, or ability to function, including maintaining a safe environment for self and others. And the insight for hoarding disorder also ranges from good to poor to absent. Trichotillomania is a recurrent pulling out of one's hair despite repeated attempts to stop. It causes significant distress or impairment in functioning. The hair pulling is not an attempt to improve a perceived defect or flaw. Excoriation disorder is recurrent skin picking that results in lesions despite attempts to stop. It results in significant distress and impairment. The behavior is not better explained by physiologic response to a substance such as methamphetamine use or intentional attempt at self-harm. And just like that, the anxiety disorder video is complete. Next up is a video on schizophrenia and psychotic disorders.